Welcome back to the deep dive. This is where we take your source material, maybe articles, research, or like today, your own detailed notes, and we really plunge in together.
Yeah, the idea is to pull out the absolute essential knowledge, kind of a shortcut, helping you get truly well informed on what you need to know.
Exactly. We navigate that info stack with you, making sure you come away with the clearest, most high-impact points. Especially helpful, when you're tackling revision for something complex.
Mm.
And for this deep dive, the source material we're working from is your MSRA pediatric revision notes, specifically focusing on urinary tract infections in children.
Right. So our mission today is pretty clear. Go through these notes section by section, unpack the crucial bits, highlight those high-yield facts you absolutely need for revision, and just make sense of it all.
We'll cover everything in your notes, starting with the definition, going all the way through to complications.
Let's do it.
Okay, let's unpack this then, starting right at the beginning, like your notes do. Defining childhood UTI. What fundamentally are we talking about here?
Well, your notes keep it simple initially. It's a bacterial infection happening anywhere within the urinary tract. So that could be the kidneys, the ureters, the bladder, or the urethra, any part of that system.
Seems straightforward, bacterial infection.
Mm.
But then the notes immediately stress why this is such a big deal in kids. It's not just any old infection.
And that's vital for revision, right? Why the fuss? Your notes flag up a few key reasons. Firstly, it could signal an underlying problem, like an abnormality in the urinary tract.
Okay, like a red flag.
Exactly. Secondly, it's actually really common, especially in kids under 2. And thirdly, and this is the really critical one, especially in neonates, those very young infants, a UTI it can escalate fast. It carries a risk of life-threatening sepsis.
Wow, okay, so that definitely elevates it. It's not just an infection, it's a potential sign of something bigger or a risk of getting seriously ill, particularly for the littlest ones.
Precisely. So when you're revising the definition from your notes, you want to link bacterial infection, any part of the tract, directly to those Y factors. Potential abnormalities common under 2, and that serious sepsis risk in neonates.
Got it.
Your notes also mention different ways to classify UTIs, things like where it is, upper versus lower, how bad, simple versus severe, if it's happened before, first versus recurrent, symptoms, asymptomatic versus symptomatic, and if there are complicating factors. Helpful context for later.
Makes sense. So building on that definition, let's look at etiology. What actually causes these most often, according to your notes?
Your notes are pretty clear on this. It's overwhelmingly bacterial, and the main culprit, like the #1 cause, is Escherichia coli.
E. coli. And that usually comes from where?
Typically originates from the child's own gastrointestinal tract. Basically, bacteria from the gut getting where they shouldn't be.
Okay, so gut bacteria, mainly E. coli, migrating up. That's the core concept.
Yeah, that's the headline, yeah. Your notes do mention other bacteria too. Specifically, Klebsiella and Proteus are listed. And importantly, they point out that underlying issues, maybe problems with the urinary tract structure or how urine flows, can really contribute. They make a child more susceptible.
Right, so E. coli is the main player, but maybe structural issues or flow problems set the stage, making infection more likely. Which takes us neatly into risk factors. Who's more likely to get a UTI based on your material?
Okay, yeah, the notes give quite a comprehensive list here. Let's break it down a bit. Demographics first, your notes mention young age, female sex, although importantly, they make an exception for very young infants, and also white ethnicity.
And history seems important too.
Huge. Having had a UTI before is a big risk factor for getting another one. Your notes mention recurrence is common, especially within that first year after the initial infection.
Okay. What else?
Voiding issues are key. So any difficulty emptying the bladder properly, that could be down to a structural issue, something like a neurogenic bladder, maybe the child just holds their urine in, or even just constipation.
Constipation. How does that link?
Well, it can physically press on the bladder and affect how well it empties. Your notes also list foreign bodies, like catheters, obviously.
Right, and anatomical things.
Yep, anatomy and genetics. Specifically, vesicoureteral reflux, VUR, that's where urine flows backwards up towards the kidneys. A family history of VUR or other kidney disease is also noted as a risk factor.
Okay.
Then there's sexual activity, though that's more relevant for older sexually active adolescents, particularly with frequent intercourse.
And anything protective mentioned.
Yes, breastfeeding is listed as potentially protective, particularly for girls. And on the flip side, immunosuppression makes a child more vulnerable, naturally.
That is quite a list. For revision, maybe focus on the big ones your notes highlight.
Yeah.
That strong link to previous UTIs, the anatomical or functional stuff like VUR and voiding problems, and those demographic points like Age and sex differences, including that interesting point about very young boys, we'll probably come back to.
Definitely.
So thinking about how it happens, let's look at pathophysiology. How does your material describe the actual mechanism?
Well, primarily it's bacteria getting into the urinary tract. Usually they ascend up from the urethra. Once they're in, they multiply, cause infection, and that triggers inflammation in the lining of the tract.
Right. And your notes mention other ways they can get in, like catheters.
Yeah, catheters, surgery, or sometimes, though less common, via the bloodstream, especially in kids with weakened immune systems.
Yeah.
And it's actually the body's own immune response to these bacteria that causes a lot of the symptoms the child feels.
Okay. And in terms of which bacteria, the notes give percentages.
They do. Reinforces what we said earlier. E. coli is the big one responsible for about 80% of cases, according to your notes. Huge proportion.
80%.
Wow. Then you've got others like Staphylococcus saprophyticus at around 4%, Klebsiella pneumonia also around 4%, and Proteus mirabilis, again, about 4%.
So the main pathway is bacteria traveling up the urethra, and E. coli is the dominant cause by far at 80%. Key takeaways there.
Absolutely. Now, important point. When a child comes in with symptoms that could be a UTI, you have to think about differential diagnosis. What else might look like this? Your notes list a few key mimics.
Right, things to rule out. What are they?
Things like bladder or kidney stones, urethritis, that's inflammation of the urethra itself, vaginal infections in girls, and in sexually active teens, you'd consider STIs.
Okay, so stones, urethritis, vaginal infections, STIs. Good list to keep in mind from the notes so you don't get tunnel vision on UTI.
Exactly. You need to consider the whole picture based on the child's presentation.
Makes sense.
Okay.
Shifting gears a bit to epidemiology. How common is this in the UK, based on your notes?
Your notes confirm it's, well, pretty common in childhood, especially in kids under 5. And generally, it's more frequent in girls than boys overall.
Are there specific numbers?
Yeah, they give some stats. Roughly 1 in 10 girls and 1 in 30 boys will have had a UTI by the time they're 16. Looking younger, before age 2, it's about 2.1% for girls and actually slightly higher, 2.2% for boys.
Interesting. Slightly higher in boys under 2.
But here's a statistic from your notes that really stands out, definitely high yield. Uncircumcised boys in their first year of life have an incidence rate that's over 8 times higher than girls or circumcised boys in that same age group.
8 times. That's a massive difference highlighted in the material. Definitely one to remember.
It really is. Your notes also point out it seems to be more prevalent in white infants compared to black infants.
Okay. And clinically relevant stats.
Yeah, your notes highlight that around 5% of children under 2 who present with a fever but no obvious source of infection, well, they'll turn out to have a UTI.
5%. That's significant when you've got a feverish baby and no clear cause.
And that percentage jumps even higher to about 30% in white girls older than 3 months who have a fever over 39 degrees Celsius, and again, no other clear cause found. For upper UTIs, pyelonephritis, your notes say it affects about 2.7% of girls and 1% of boys by age 7.
Okay, those specific numbers, especially the uncircumcised boys under 1 and the fever with no source scenarios, definitely feel high yield. Worth comparing those rates in your mind.
Definitely. Now let's move on to clinical features. This is super crucial for actually recognizing a UTI, and your notes break it down really clearly by age group, which is helpful because it presents differently.
Right. So for the really little ones, infants under 3 months.
Here, the symptoms listed are quite nonspecific, which can make it tricky. Things like fever, vomiting, being lethargic or irritable, not feeding well, maybe some abdominal pain.
So general unwell baby signs.
Pretty much. Less commonly, your notes mention jaundice, blood in the urine, hematuria, or smelly urine. The really key things highlighted here are the high risk of urosepsis in this age group, and also that E. coli is actually less likely to be the cause compared to older kids. Different bugs sometimes in neonates.
Okay, under 3 months, non-specific symptoms, high sepsis risk, maybe not E. coli. Got it. What about infants and preverbal kids, say 3 months and older?
List is pretty similar initially. Fever, tummy pain, maybe loin tenderness, vomiting, poor feeding, lethargy, irritability. Again, less common are things like hematuria, offensive urine, or failure to thrive. But your notes make a really important distinction here.
Which is?
While things like weeing more often, frequency, and pain on weeing, dysuria, are common signs in verbal children who can tell you, the big red flag in the preverbal group is often just that, fever with no obvious cause.
Ah, okay. So fever without source in a preverbal child should really make you think UTI.
Exactly. Then for older children, over 3 years old, your notes say you're more likely to see those classic specific urinary symptoms. Frequency, dysuria, pain low down in the tummy, suprapubic, or in the abdomen or loin area.
More like adult symptoms.
Kind of, yeah. Your notes also mention you might see dysfunctional voiding habits or changes in continence, like suddenly starting to wet the bed again. Less commonly listed for this age group are fever, feeling generally unwell, malaise, vomiting, hematuria, or cloudy or smelly urine.
Right, and your notes have those really useful lists, don't they? Things that make UTI more likely versus less likely.
Yes, vital lists for clinical practice. The increasing likelihood list includes painful urination, dysuria, frequent urination, new bedwetting, foul-smelling urine, darker or cloudy urine, visible blood, drinking less, fever, shivering, abdominal pain, tenderness in the loin or suprapubic area, slow capillary refill over 3 seconds, and of course, a previous confirmed UTI.
That's a lot.
It is. And then the decreasing likelihood list includes things like no pain on urination, having a nappy rash, breathing problems, abnormal chest or ear findings on exam, and importantly, having a fever where you've clearly identified another cause.
Okay, those lists are gold. Maybe thinking about the types of symptoms helps stuff directly related to urine itself, pain in the right areas, systemic signs like fever, and that history. So if you've got, say, a 4-year-old who suddenly starts wetting the bed, says their tummy hurts and their wee smells bad, based on these lists from your notes, UTI should jump right out, shouldn't it?
Absolutely. New bedwetting, abdominal pain, smelly urine, all classic flags from that increasing likelihood list. It's about spotting those patterns your notes highlight.
Okay, so we suspect a UTI based on the clinical picture. How do we actually confirm it? Let's talk investigations.
Right. Your notes really focus on urine testing here. And the absolute golden rule, repeated often. Always, always get the urine sample before you start any antibiotics.
Sample first, drugs second. Got it. What about different age groups?
For infants under 3 months with a suspected UTI, your notes say it's urgent. They need microscopy and culture done quickly, plus a specialist referral straight away.
Urgent referral for under 3 months.
Okay. For children 3 months and older, urine testing is needed if they have symptoms suggesting UTI or if there's just uncertainty about the diagnosis.
And the dipstick. How does that fit in?
Crucial, especially for kids aged 3 months up to 3 years. Your notes give a very clear pathway for using the urine dipstick here. If both leukocyte esterase and nitrite tests are negative,
Both negative.
then your notes say you generally don't need to send for culture or give antibiotics unless there are specific clinical reasons to be worried.
Okay, but what if one or both are positive?
That's the key decision point. If either leukocyte esterase or nitrite is positive, or if both are, then the notes say you must send that urine sample for culture, and you should start antibiotics empirically while waiting for the results.
Right. So it's like a clear flow chart in your notes for that 3-month to 3-year group. Dipstick, both negative, hold off free, either or both positive. Send culture and start antibiotics.
Exactly that. A really practical pathway. Your notes also cover imaging tests. They mention these are mostly done in secondary care, so in hospital, and they aren't routine just to pinpoint where the infection is in a straightforward case.
But sometimes imaging is needed.
Yes. If it looks like an acute upper UTI, so pyelonephritis, and it's clinically significant, your notes suggest considering power Doppler ultrasound or a special kidney scan called a DMSA scan. The exact timing and type of imaging really depend on the child's age and whether the UTI is classed as atypical or recurrent.
Okay, so how do the notes break down those imaging schedules?
For babies under 6 months who have an atypical or recurrent UTI, or maybe aren't responding well to treatment, your notes recommend doing an ultrasound and a DMSA scan. There's another test, an MCU micturating cystourethrogram.
That's the one that looks for reflux, right?
Exactly, VUR. Your notes say this is only done if there are specific features suggesting it might be present, not routine.
Okay. And for older kids, say 6 months to 3 years.
For this group, ultrasound is recommended for atypical UTIs, or within 6 weeks if it's recurrent. DMSA is also for atypical or recurrent cases, but your notes specifically state NO routine MCUG in this age group.
No routine MCUG between 6 months and 3 years.
Mm-hmm.
Clear. And older than 3.
Similar pattern. Ultrasound for atypical or within 6 weeks for recurrent. DMSA is mainly for recurrent UTIs. And again, NO routine MCUG. Your notes add a practical point. For kids who are toilet trained, the ultrasound should ideally be done with a full bladder, and then they measure the volume before and after weeing to check emptying.
Right. So the key for memory seems to be ultrasound often first look for anatomy. The MSA is more about kidney tissue damage or scarring, especially thinking about upper UTIs. And MCG is specifically for VUR, but, and this is a recurring point in your notes, it's not routine, especially after infancy.
Well summarized. Okay, so we've got the diagnosis confirmed. How do we treat it? Management. Your notes lay out the general principles first. Things like antibiotics, obviously tailored to the specific bacteria if possible, keeping the child well hydrated, managing symptoms like pain or fever, addressing any underlying risk factors like constipation, and making sure there's proper follow-up.
And your notes mention some further investigations might happen as part of management too.
Yes, things like repeating urine tests if needed, doing those DMSA scans maybe 4-6 months after the infection, specifically to look for any kidney scarring, and potentially doing an MCUG if VUR is suspected based on other findings.
Okay. What about the acute management, the immediate treatment?
Your notes say high-risk cases or kids who are very unwell need urgent referral to hospital. Infants under 3 months generally need immediate referral and often start on IV, intravenous antibiotics.
Makes sense given the sepsis risk.
Yeah, definitely. Children over 3 months who clearly have signs of an upper UTI, pyelonephritis, also usually need referral. For treating confirmed acute pyelonephritis, your notes list oral options like cephalexin or coamoxiclav if the child isn't too unwell.
And if they're more severe,
Then it's IV antibiotics. Your notes mention options like coamoxiclav, cefuroximab, ceftriaxone, or gentamicin. A really important point your notes make here is about the transition. You aim to switch from IV to oral antibiotics, usually within about 48 hours, provided the child is improving, and you have culture results guiding the choice.
that IV to oral switch within 48 hours is a key clinical point then. What about the simpler, lower UTIs? Cystitis.
For cystitis, your notes recommend oral antibiotics. Examples given are trimethoprim or nitrofurantoin. You'd consider alternatives if the symptoms get worse or the first choice isn't suitable for some reason.
And the duration for lower UTI. Your notes are specific, aren't they?
Yes, very specific and high yield. 3 days. Just a 3-day course for uncomplicated cystitis according to your notes.
3 days. Got it. What about follow-up after treatment?
Your notes state that routine follow-up isn't usually needed for children who didn't have any significant findings on imaging, if imaging was done. However, children who have recurrent UTIs, or if imaging did show abnormalities, should be referred to specialists to look into potential underlying causes or kidney defects.
Okay. And preventing it happening
And
again.
the notes cover this too. Address things like constipation or poor bladder emptying habits, encourage drinking plenty of fluids, making sure they go to the toilet regularly and don't hold on, and ensuring clean toilet access. And then there's a really critical rule, which your notes emphasize again later.
Let me guess. Prophylactic antibiotics.
You got it. The notes are clear. Avoid routine prophylactic antibiotics after a first uncomplicated UTI.
Right. That seems like a really key message from your material. So comparing treatments for revision. Upper UTI, pyelonephritis is the more serious one, might need IV initially, then oral, longer course. Lower UTI cystitis is usually just oral antibiotics for that specific 3-day duration. And crucially, no routine prophylaxis after the first one.
Precisely. That prophylaxis rule is absolutely central in your notes.
Okay, let's look ahead then. Prognosis. What's the general outlook, according to your notes?
Generally, the notes are quite reassuring. They state the prognosis is usually good, provided it's diagnosed promptly and treated properly. Most kids recover fully without any long-term problems.
That's good news.
It is, but, and it's an important but in the notes, children who have recurrent UTIs or those found to have underlying structural abnormalities, well, they might need more ongoing management and monitoring.
Right. So good overall, but watch out for recurrence and underlying issues.
Exactly. And the notes bring up those prevention methods again here. Managing voiding issues, good hygiene, avoiding constipation, drinking enough, not delaying weeing. Standard stuff, but important.
And the antibiotic prophylaxis point comes up again.
It does, really reinforcing the nuances. Your notes say prophylaxis might be considered, after investigation, for children with recurrent UTIs. But they are very, very firm that asymptomatic bacteriuria that's finding bacteria in the urine when the child has absolutely no symptoms should not be treated with prophylactic antibiotics.
Okay, crystal clear from the notes. Recurrent might get prophylaxis after investigation. Asymptomatic never gets prophylaxis.
That's the message. So generally good outlook, but be aware of recurrence, underlying issues, and be absolutely solid on those prophylaxis rules.
Which leads us nicely, if slightly worryingly, to complications. What can go wrong long term? Your notes list the potential serious outcomes.
Yeah, this is why getting it right is so important. The main concern highlighted is renal scarring, kidney scarring. Your notes estimate this happens in about 5% of childhood UTI cases, and it's more likely if there's severe VUR, that reflux we mentioned.
And that scarring can cause other problems.
It can. Your notes mention a slightly increased risk of developing hypertension, high blood pressure later on, especially if the scarring is severe or affects both kidneys. And perhaps most significantly, your notes explicitly state there's a link between childhood UTIs and an increased risk of developing renal failure later in childhood or even adulthood.
Wow. Scarring, hypertension risk, and even potential renal failure down the line. These are serious long-term consequences mentioned in your material.
They really are, and they underline why managing every UTI properly in childhood is so vital. Your notes, yet again, repeat the prevention points here. Hygiene, constipation, timely voiding, and hammer home those prophylaxis rules one last time. Not routine after first, consider for recurrent, do not treat asymptomatic bacteriuria.
Seems like the notes really want you to remember the prophylaxis rules.
They certainly emphasize it repeatedly. Oh, and they also add a quick note about probiotics, just stating that current evidence doesn't show they're effective in preventing UTIs in kids or adults.
Okay, so key complications from the notes. Scarring, hypertension risk, linked to renal failure. And nail down those prophylaxis rules.
All in one.
Right, well, we've done it. We've navigated all the way through your MSRA pediatric revision notes on urinary tract infections in children, section by section.
Yeah, we really aim to distill all that information, pull out those high-yield nuggets, connect the dots between the sections, and just spotlight the key facts, stats, and rules from your source material that are going to be most helpful for your revision.
And considering everything your notes have shown us, from that immediate risk of sepsis in babies, right through to those potential long-term consequences like kidney scarring, high blood pressure, even kidney failure later in life.
Yeah.
What does that really tell us? It seems a powerful underlying message from your notes is just how critical it is to take every single suspected UTI in a child seriously, to investigate it properly, manage it effectively, no matter how minor it might seem initially. Does that sound right?
That sounds absolutely right. That's the profound implication. So take these key points, use them in your revision, keep digging deeper.
And if you are preparing for the MSRA, definitely check out passthemsra.com.
Yeah, and for even more resources that might help your studies, have a look at freemsra.com as well.
You've got this. Keep up the great work.